Good evening, my dear friends and colleagues. Today we will discuss an important topic in nephrology, which is systemic vasculitis and their relation to the kidney. Its importance comes from its severity on kidney affection, because these conditions or renal vasculitis, if not diagnosed early, usually it will cause end-stage renal disease due to their affection to the kidney in the form of crescentic glomerulonephritis. So it is very important to diagnose them early as soon as possible and to start immunosuppression early. Systemic vasculitis is an inflammation of the blood vessels. Usually it affects the blood vessels all over the body, including vessels of the kidney. It has a very wide range of clinical manifestations. As we said, it can affect blood vessels in all organs of the body, but their classifications depends mainly on the size of the vessel to divide them to three categories: large vessel vasculitis, medium-sized vessel vasculitis, and small vessel vasculitis. And they are classified according to Chapel Hill classification, according to their size, as we said. This is the classification. First of all, they are divided to large vessel vasculitis, as we said, or medium-sized, or small vessel, which is our main topic. Because small vessel vasculitis, they are the main type of vasculitis affecting the kidney. Large vessel and medium-sized vessel. Large vessel vasculitis, the two most important examples for large vessel vasculitis is giant cell arthritis and Takayasu arthritis, and we will discuss them at this topic, at this lecture, inshallah, at the end. Giant cell arthritis, as we are going to discuss, usually affects elderly people more than 50 years of age, and Takayasu will affect people less than 50 years of age, and both of them affect large vessels, especially the aorta and its main branches. While the medium-sized vessel vasculitis, the two most important examples are polyarthritis nodosa and Kawasaki. Polyarthritis, both of them, there is necrotizing arthritis in both of them. But in Kawasaki, there is what is called mucocutaneous lymph node syndrome. We will discuss it later. Mucocutaneous lymph node syndrome, but it is not present, this lymph node and mucocutaneous manifestations, in polyarthritis nodosa, and we'll give a hint at the end of this lecture about these types: giant cell Takayasu and polyarthritis and Kawasaki. Now let's go for our main topic today, which is small vessel vasculitis. Small vessel vasculitis are divided according to the pathogenesis, either to immune complex mediated vasculitis, they are mainly mediated through immune complexes, or there is no or very few immune complexes, it is called Busi immune vasculitis, when there is very few or no immune complexes, and they are usually associated with ANCA antibodies, anti-neutrophil cytoplasmic antibodies. So immune complex mediated, or Busi immune, or ANCA associated. Immune complex mediated, they are divided. They can be mediated through cryoglobulins in the blood, so it is called cryoglobulinic vasculitis, or through IgA immunoglobulin A, so it's called IgA vasculitis, or through systemic lupus or rheumatoid arthritis. They are autoimmune disorders characterized by immune complex formations, and both of them can cause vasculitis, either lupus or rheumatoid vasculitis, or any other source for immune complexes, and these immune complexes mediate the injury to the blood vessels. So these are the most common causes of immune complex small vessel vasculitis: again, cryoglobulins, IgA, systemic lupus or rheumatoid. What about the immune or ANCA-associated vasculitis? The immune or ANCA-associated vasculitis are mainly caused by, the examples include Wagner granulomatosis with its new name granulomatosis with polyangiitis, or Church-Strauss with its new name eosinophilic granulomatosis with polyangiitis, and microscopic polyangiitis. These are the prototypes or the main types causing immune or ANCA-associated vasculitis. Again, Wagner or granulomatosis with polyangiitis, Church-Strauss eosinophilic granulomatosis with polyangiitis, and microscopic polyangiitis. They are divided according to granuloma, if there is granuloma formations. In microscopic polyangiitis, no granuloma formation, while in Wagner and Church-Strauss there is granulomas. But in Church-Strauss there is also asthma and eosinophilia. These are the most important, and never to forget about Church-Strauss. There is asthma, history of asthma, and eosinophilia to differentiate. As we are going to discuss, you should know the main characteristic for each type and how to diagnose. Church-Strauss is characterized by mainly asthma and eosinophilia. Now let's go in depth with our main topic, immune or ANCA-associated vasculitis. The epidemiology. The main three types of ANCA-associated vasculitis, Wagner, microscopic polyangiitis, or Church-Strauss, or its new name as we said, usually affect the 5th, 6th, and 7th decades, with a peak incidence of 65 to 75 of each, but never to forget that they can affect any age. Elderly are commonly affected, but we have seen cases in 30s, 40s, and 50s. There is also slight male predominance, and this is observed in our clinical practice. There is slight male predominance. In UK, United Kingdom, granulomatosis polyangiitis or Wagner is the highest from the three types, is more common than microscopic polyangiitis, followed by Church-Strauss or eosinophilic granulomatosis polyangiitis. So Wagner, microscopic, then eosinophilic. In France, these vasculitis are twice as high in other Europeans. In North America, these types of vasculitis are more common in whites than in African Americans. What about the pathogenesis? Regarding the pathogenesis, usually it starts by priming of neutrophils by cytokines, and usually start by viral infection, mostly causing these neutrophils to move these ANCA antigens to the cell surface. So ANCA antigens will move to the cell surface, and then ANCA antibodies will bind to these antigens. So antigens will bind the ANCA antibodies. Then FC and FAB will usually bind this ANCA antigen complex, leading to neutrophil activation, accompanied by activation of the alternative complement pathway that will amplify this inflammation. This will lead to, at the end, to apoptosis and necrosis of neutrophils and generation of toxic oxygen metabolites and release of lytic enzymes that will affect the endothelial cells, causing vasculitis at the end. What about the clinical manifestations? Mostly there will be generalized non-specific manifestations in most of the types that will include fever, malaise, anorexia, weight loss, myalgia, and arthralgia, and often they are present, very common to be present in most of the cases. So generalized non-specific manifestations. What about the renal involvement? And this is very important regarding our field, the kidney affection. Kidney affection in pussy-immune or ANCA-associated vasculitis usually occur, or it is more common with granulopatosis with polyangiitis or Wagner and microscopic polyangiitis, and it is uncommon with Church-Strauss. So kidney affection is more common in Wagner and microscopic. And what is the most common renal manifestations? Usually these types of vasculitis affect the kidney in the form of nephritic presentation and RBGM, nephritic presentation. So they usually cause hematuria and proteinuria and renal impairment and rapid deterioration of kidney function. Again, this renal failure or renal impairment usually in the form of rapidly progressive glomerulonephritis. What is meant by rapidly progressive glomerulonephritis is that we found our patient to have a creatinine of 2, the next day 4, the day after 6, 8, and 10. Very rapid deterioration of the kidney function. This is what is meant by rapidly progressive glomerulonephritis. And this is very common, as we said, in Wagner and microscopic, and less common with Church-Strauss or eosinophilic granulomatosis polyangiitis. So kidney affection is in the form of nephritic, severe nephritic, and RBGM. What about the skin involvement in vasculitis? And skin manifestations or skin involvement is very common in these types of vasculitis. Purpura is a manifestation in all of them, and this purpura is usually affecting mainly the lower extremities, and it tends to occur as recurrent crops. And usually there is ulcerations and nodular cutaneous lesions are present in these types of vasculitis. In the form of skin rash, there is a skin rash with vasculitis. What about respiratory tract? Respiratory tract affection is mainly divided to upper respiratory tract affection and lower respiratory tract affection. The upper respiratory tract affection is usually, and never to forget, is very, very common with granulomatosis with polyangiitis or Wagner. So again, upper respiratory tract affection is very common with Wagner or granulomatosis with polyangiitis, but it is less common with Church-Strauss and microscopic. So it is very common with Wagner. Lower respiratory tract affection usually occurs in all the three types in the form of pulmonary affection. Mainly, the main form is pulmonary hemorrhage and aggressive dyspnea and progressive dyspnea due to this pulmonary hemorrhage. Again, what are the picture or the clinical picture of this upper respiratory tract affection? It usually includes subglottic stenosis, sinusitis, rhinitis, nasal septal collapse, it's very common, otitis media, and ocular inflammation. Again, it is most common with Wagner or granulomatosis with polyangiitis. And it can lead to, in some cases, to septal perforation and saddle-shaped nose. This is very important for your clinical life and for the exam. To any patient is going to have a master degree or MD exam or a European specialty examination. What about the cardiac affection? The heart can be affected in around 50% of patients with Church-Strauss or eosinophilic granulomatosis polyangiitis in the form of myocarditis, but it is less common in other types. So heart affection is more common with Church-Strauss. It can lead to, in some cases, to transient heart block and ventricular hypokinesia. And these conditions are usually responsive to immunosuppressive treatment. What about in neurological manifestations in these types of vasculitis? The most common form is peripheral neuropathy, and it usually to take a mononeuritis multiplex pattern, and it is the most common neurological manifestation, a mononeuritis multiplex pattern of peripheral neuropathy. Central nervous system involvement is less common with vasculitis, and as we said, peripheral neuropathy is the most common manifestation. This table is very nice to summarize the clinical picture or the system affection in all types, showing the frequency. Now let's discuss with microscopic polyangiitis. I am highlighting the most important points. So in microscopic polyangiitis, the most important is kidney affection. Kidney affection in around 90% of patients, there will be kidney affection. All other systems can be affected in patients with microscopic polyangiitis, but to a lower frequency. What about granulomatosis polyangiitis or Wagner? Now let's focus. Kidney is very high, lower respiratory tract is very high, and the upper respiratory tract. This is very important. This is very characteristic for Wagner. So Wagner, kidney, lower respiratory tract, and upper respiratory tract. As we said, nasal septal perforation, saddle-shaped nose, rhinitis, sinusitis is very important. What about Church-Strauss or eosinophilic granulomatosis polyangiitis? Kidney affection, to notice, is less common, but it is characterized by what? Asthma, lung affection, especially in the form of asthma. It can also affect as pulmonary hemorrhage, as we said, but usually there is a history of asthma. Upper respiratory tract can be present in Church-Strauss, but it is less common than Wagner. But don't forget that with Church-Strauss or eosinophilic granulomatosis polyangiitis, there is also eosinophilia. What about IgA vasculitis? IgA vasculitis or Hennoch's line, purpura. The most important manifestation is skin manifestations. There is a vasculitic rash, especially in the lower limb and buttocks, and there is also GIT manifestations. This very characteristic GIT manifestations is a form of intussusception and abdominal pain. There is also arthritis in patients with IgA vasculitis or Hennoch's line purpura. So don't forget, and there is also the kidney affection. So in IgA vasculitis, there is vasculitic rash in the lower limb and buttocks, intussusception and abdominal pain, and it can lead to some bowel ischemia, arthritis, and kidney affection. What about cryoglobulinemia? Cryoglobulinemia, also, as we said, the most important is skin manifestations, cryoglobulinemia, vasculitic rash, and there is kidney affection, and there is arthritis. Usually there is arthritis with cryoglobulins and cryoglobulins in serum. So this table is very important for summarization of the clinical manifestations with characteristics of each of them. This is a very nice picture showing the vasculitic rash with ulcerations. Usually it is raised that don't fade with pressure. Usually it is raised over the skin and don't fade with pressure, and usually showing some ulcerations. Very nice, and don't forget this picture to diagnose your patient. Now let's discuss about the ANCA, Antineutrophilic cytoplasmic antibodies. To take some notes about the ANCA and how to use them. الأنكا can be divided to C ANCA or cytoplasmic, C from cytoplasmic, or B ANCA from perinuclear. So it can be divided to C ANCA or B ANCA. According to staining, if the staining is all over the cytoplasm, diffusely all over the cytoplasm, it's called cytoplasmic or C ANCA. Or either it is very nuclear, so it's called B ANCA. By enzyme immunoassay, most of the C ANCA have a specificity for proteinase 3 ANCA. So C ANCA, don't forget that, C ANCA or proteinase 3 ANCA. We can use either of them in clinical practice and in the exam. You should know that C ANCA is proteinase 3 ANCA, and most of the B ANCA have specificity for myeloperoxidase ANCA. Very important. C proteinase 3, B ANCA myeloperoxidase. Don't forget that, and you should know both names. Now let's discuss about, is there a possibility that this ANCA test can be false positive? By other explanation, can ANCA be positive in other conditions other than vasculitis? Yes, ANCA can be positive with other inflammatory diseases other than vasculitis, can be false positive, and usually what is the positive, C or B? Usually it is B ANCA that can be positive with other inflammatory conditions. Don't forget that, can be a question. Type. What are these other inflammatory conditions? It might be with inflammatory bowel disease, rheumatoid disease, rheumatoid arthritis, chronic inflammatory liver disease, infective endocarditis, and cystic fibrosis. In all these conditions, ANCA can be positive, and usually it is B ANCA, and this can happen in around 25% of cases. What about what is called double positivity for ANCA and anti-GBM? Can we find a patient to have ANCA and anti-GBM antibodies positive in the same patient? Yes, we can find that. ANCA are very good sensitive for ANCA-associated vasculitis. They are very sensitive, very sensitive. But in around 1/4 to 1/3 of patients with anti-GBM, with anti-GBM crescentic glomerulonephritis, and 1/4 of patients with immune complex crescentic glomerulonephritis, we are ANCA positive. So in around 1/4, 25 to around 33% of patients with anti-GBM disease, they are usually also ANCA positive. We're saying them double positive patient for ANCA and anti-GBM. And those patients usually, unfortunately, have a worse prognosis. Have worse prognosis than those patients with ANCA positive alone. What about the titr? What about الأنكا titr? Changes in the ANCA titr over time may correlate, and be cautious with every word I'm going to say. This is a very important slide in our practice. Changes in ANCA titr may correlate with the disease activity, but these changes must be interpreted with caution. Why? In generally speaking, that these titr usually decrease with treatment. As the patient is improving, usually this titr decrease, and also they can increase before or as with disease relapse. They decrease with treatment and increase with relapse. Very important. Type. But if we found an increase in ANCA-titer, we should do careful evaluation of the patient clinical condition. And very important, this is very important statement. Most physicians don't modify treatment based on the change on the titer without any clinical manifestations or clinical evidence of relapse. To clarify this statement, if I found a patient that with ANCA-associated vasculitis that received treatment and the ANCA titer going very low, and then with follow-up visits, I found that this patient have showing an increase in the ANCA titer. If I found an increase in the ANCA titer, then I should evaluate my patient clinically. If there is clinical evidence of relapse, accompanied by increase in the ANCA titer, so this is a relapse and I should augment or give the immunosuppression. But if I found an increase in the titer without any clinical manifestations of a relapse, don't increase the immunosuppression, but increase the follow-up and check for the ANCA titer again at follow-up visits. So don't modify your treatment protocol and immunosuppression according to change in the ANCA titer alone without clinical manifestations of relapse. Very important slide. Can we find patient with ANCA-associated vasculitis or small vessel vasculitis without and the ANCA is negative? Yes. Around 10 to 20 patients with immune vasculitis are ANCA negative. 10 to 20% of patients with immune vasculitis are ANCA negative. And those patients and their clinical characteristics and outcome are not different from ANCA positive patients. Also, an important table showing the frequency or the frequency of ANCA C or B or proteinase 3 in different types of vasculitis. Very important. In Wagner or granulomatosis with polyangiitis, as we said, usually type of ANCA in Wagner is C ANCA or proteinase 3 ANCA. Very important. It can be B ANCA can be positive, yes, in 25%, and it can be negative only in 5%. But the most common is C ANCA or proteinase 3. In microscopic polyangiitis, take care. It can be both C ANCA, or B ANCA. C ANCA in 40% of patients and B ANCA in 50% of patients, and it can be negative in 10% of patients. So in microscopic, usually it is nearly equal with a slight increase in the incidence to be B ANCA positive. What about the Church-Strauss or the eosinophilic granulomatosis? It is mainly B ANCA. It is very rare to find Church-Strauss with C ANCA. Very, very rare. It is mainly B ANCA, or very high percentage, or 55% of patients will be ANCA negative. And take care that the most common type of vasculitis to be ANCA negative is Church-Strauss in 50% of patients. Renal limited vasculitis. What is meant by renal limited immune vasculitis? It means that the patient to have vasculitis, small vessel vasculitis, only in the vessels of the kidney without systemic manifestations. That these patients have proteinuria, hematuria, or kidney affection, but without respiratory tract affection, without heart affection or neurological affection or skin affection. It is only kidney affection. And these types of patients are called renal limited vasculitis. Those patients with renal limited vasculitis are usually B ANCA positive. B ANCA positive. So again, Wagner mainly C ANCA, microscopic polyangiitis C ANCA and B ANCA, Church-Strauss mainly B ANCA and negative for ANCA, renal limited vasculitis mainly B ANCA. Very important slide for your practice and for the exams as well. Now let's discuss the pathology. To summarize, immune vasculitis are characterized by necrotizing crescentic glomerulonephritis. Necrotizing crescentic glomerulonephritis. So the acute vascular affection is mainly of the form of segmental fibrinoid necrosis. It is mainly necrosis. It is a necrotizing affection of the blood vessels and glomeruli. Segmental fibrinoid necrosis, usually accompanied by leukocyte infiltrations and leukocytoclasia and leukocyte fragmentation, an important sign for activity. This acute necrotizing lesions usually very rapidly to evolve into sclerosis, and they can be accompanied by thrombosis. So the main affection is necrosis and necrotizing lesions, usually accompanied by crescent formations. Vasculitis are very common cause of crescents or crescentic glomerulonephritis. The two most important diseases to cause crescents in the kidney are anti-GBM disease and ANCA-associated vasculitis. So again, the main pathology or the main histological manifestation is necrotizing crescentic glomerulonephritis. Severe cases are usually characterized by global necrosis and large circumferential crescents. This is a picture showing fibrinoid necrosis. This is also another picture showing necrosis and an area of crescent formation. What is crescent? Crescent is cells in the Bowman's space. Very fine area, a very fine picture showing area of necrosis and circumferential crescent obliterating the Bowman's space. And this explains why the urine output in these patients are usually very few, and most of the patients are usually oliguric and anuric and usually dialysis dependent. Let's discuss the differential diagnosis. Microscopic polyangiitis. Usually there is, as we said, all of them have vasculitis, but in microscopic polyangiitis there is usually ANCA in the blood. In granulomatosis polyangiitis or Wagner, there is ANCA in the blood with granulomas mainly affect the kidney and upper and lower respiratory tract. Church-Strauss is usually characterized by ANCA, granulomas, and asthma and eosinophilia. Don't forget that, as we said, asthma and eosinophilia. But IgA vasculitis and the cryoglomerulonic vasculitis, which are immune complex mediated, these three types are Busi immune or ANCA associated, and these types are immune complex mediated IgA and the cryoglobulins. IgA vasculitis or hemorrhagic purpura characterized by IgA deposits in the kidney, IgA deposits, and usually there is also, as we said before, this skin rash or vasculitic rash is mainly in the lower limbs and buttocks. GIT manifestations in the form of intussusception or intestinal perforation and arthritis. Cryoglobulinic vasculitis, characterized by the presence of cryoglobulins in the blood, usually associated with arthritis, hypertension, rheumatoid factor positive, and consumed complement 4. Now let's give a talk or a hint about the large vessel vasculitis. As we said in the beginning, that the examples for large vessel vasculitis include Takayasu arthritis and giant cell arthritis, both of them affecting large vessels, mainly aorta and its major branches, both of them. But the main difference is that Takayasu usually affect patients that's younger than 50 years of age, but giant cell arthritis or temporal arthritis mainly usually affect people or patients more than 50 years of age. Takayasu Takayasu arthritis usually affects the major vessels affecting major arteries affecting supplying the extremities, while the giant cell arthritis usually affects the extracranial branches of carotid artery. So usually Takayasu affecting arteries supplying extremities, while the giant cell usually affect the extracranial branches of the carotid artery. Usually the most commonly affected is temporal artery. They can also affect vessel supplying the eye. They might cause blindness. As we said that Takayasu usually affect the vessels supplying extremities, so the main clinical manifestations of Takayasu usually include reduced pulse in most of the patients, vascular bruit and claudications, so reduced pulse in the extremities. While in giant cell arthritis, the main clinical manifestation is headache due to temporal artery affection. They might also manifest with temporal artery tenderness and decreased pulsations in half of patients. Usually also they can manifest with blindness, deafness, and jaw claudications in some cases. What about the medium vessel vasculitis? The two examples include polyarthritis nodosa and Kawasaki disease. As we said in the start, usually with Kawasaki there is mucocutaneous lymph node syndrome, but this is not common with polyarthritis nodosa. There is no mucocutaneous lymph node syndrome in polyarthritis nodosa. Polyarthritis nodosa is not associated with ANCA. It is usually associated with hepatitis B virus infection in around 60% of patients. The clinical picture of polyarthritis nodosa usually include non-specific manifestations like fever, malaise, and arthralgia, but it has some peculiar affection, including weight loss, mononeuritis multiplex affection, epididymoorchitis, GIT involvement, which is present in around 50% of patients in the form manifested by abdominal pain and blood, bowel infarction and perforation can happen, arterial aneurysm can also occur in some of patients, and there is also skin manifestations. Arterial aneurysm are very common, can be diagnosed by angiography in patients with polyarthritis nodosa. Don't forget that polyarthritis nodosa are associated with hepatitis B virus infection. There is mononeuritis multiplex, weight loss, and epididymoorchitis, and there is GIT affection. What about the Kawasaki disease? Kawasaki disease is usually a disease of children, usually less than 5 years of age. It was first described in Japan. As we said, it is characterized by what is called mucocutaneous lymph node syndrome. What is meant by this term? It usually includes fever and mucosal inflammation and lymphadenopathy. This mucosal inflammation usually include, I am usually describe them as red patients. They are usually have swollen red tongue, what is called strawberry tongue, erythematous rash, erythematous or erythema of the palm and soles, and conjunctival injection. They are usually red. Red skin, red eye, red tongue. What is very important in them that there is high incidence of coronary affection. Coronary affection in patients with Kawasaki disease. And this inflammation of the coronary arteries can be accompanied by thrombosis, causing myocardial infarction in this very young age. And this is a very important, it is usually considered as the most common cause of childhood myocardial infarction, this Kawasaki disease. And there is also a very, very important note that corticosteroids, which are usually given to treat any form of vasculitis, they are very risky in Kawasaki disease because steroids usually increase the risk for coronary artery aneurysm in those patients. We don't rush to give steroids in patients with Kawasaki disease for the fear of coronary artery aneurysm. Kawasaki disease children are usually treated by IVIG and aspirin. We reach small vessel vasculitis. We discussed them before, but to summarize, small vessel vasculitis are either immune complex mediated or Busi-immune. Busi-immune, we discussed them in details, but what about the immune complex mediated vasculitis? They can be anti-GBM disease, and we discuss it in another video. Anti-GBM disease, usually antibodies against glomerular basement membrane disease or anti-glomerular basement membrane. They are usually affect basement membranes of the lung and kidney, causing pulmonary affection in the form of pulmonary hemorrhage, mainly in pulmonary edema, and kidney in the form of severe nephritic proteinuria, hematuria, and rapidly progressive glomerulonephritis with the form of crescentic glomerulonephritis. Cryoglobulins, as we said, usually characterized by cryoglobulins in the serum with skin rash, as we said before, with arthritis and rheumatoid factor positive and consumed C4. IgA vasculitis or Henoch-Schönlein purpura are usually characterized by IgA immunoglobulin deposition in the kidney. Usually there is vasculitic rash in the lower limb and buttocks and GIT manifestation and arthritis, as we said. There is also what is called hypocomplementemic urticarial vasculitis or anti-C1q vasculitis. It's characterized by urticaria and decreased complement and usually associated with anti-C1q antibodies. There is usually glomerulonephritis, arthritis, and obstructive pulmonary disease and ocular manifestations. Obstructive pulmonary disease and ocular manifestations in patients with anti-C1q vasculitis. This is our part 1. In part 2, inshallah, we will discuss treatment in details. Thank you, and we will continue in part 2, inshallah. Thanks.